Hi, my name is Sophia Lynn. I am the Director of Emergency Ultrasound at Weill Cornell in New York City. So for the next 15 or 20 minutes, we're going to discuss the use of ultrasound measured optic nerve sheath diameter in evaluating pediatric patients presenting to the ED with concerns for VP shunt failure. So some background, there are about 16,000 visits annually to the emergency department for children with VP shunts who present with concerns for shunt failure. About 13% of these patients actually end up having shunt malfunction, which is defined as requiring surgical revision. This can be a difficult diagnosis to make because presenting symptoms are often nonspecific. So symptoms like headache, fatigue, poor feeding, nausea, vomiting, these symptoms overlap with non-shunt related diagnoses such as viral illnesses. Because of the potentially devastating consequences of missing shunt malfunction, we get imaging on these kids, either CT or rapid MRI. In one study looking at how many CT scans these children get, children with VP shunts underwent a mean of 0.65 CT scans per year. And so what that means is that children with VP shunts present for multiple years get multiple CTs. There's an obvious downside in that these kids get exposed to a lot of radiation from the CT scan, which increases the risk for malignancy later in life. In some centers, rapid MRI has replaced CT scan, but the disadvantages of this are the cost of the MRI. In some places, MRI may not be available or may take quite a while to actually get the rapid MRI. So another study that can be used to help evaluate these patients is measuring optic nerve sheath diameter using point-of-care ultrasound. So to briefly review the anatomy behind this, the optic nerve perineural space is continuous with the subarachnoid space. And so because of this, changes in ICP are reflected in the diameter of the optic nerve sheath. When ICP increases, optic nerve sheath diameter increases. The response is quick, usually within minutes, and there's good data from the adult literature supporting the use of ultrasound measured optic nerve sheath diameter to detect elevated ICP. Data in the pediatric population is less definitive, and this may be because of several pediatric specific factors, which we'll discuss later in this talk. So I think that in children with VP shunts who present with concerns for shunt malfunction, the real utility of measuring optic nerve sheath diameter on ultrasound is figuring out which of these children you need to be more worried about, which ones you need to really push for getting their CT or rapid MRI immediately and getting neurosurgery on board with their evaluation. So when should you consider this application? So you should consider this in pediatric patients who have a VP shunt who are presenting to the ED for possible shunt malfunction. And again, their symptoms can be very nonspecific. So nausea, vomiting, poor feeding, lethargy, irritability. Because determining which of these patients actually needs surgical intervention can be a complicated decision, all these patients are going to need neurosurgery involved in their evaluation in the ED. Just a reminder, ocular point-of-care ultrasound should not be performed when there's any concern for globe rupture. This is a contraindication to ocular point-of-care ultrasound. For this application, because the structures of interest are superficial, you want to use a high-frequency linear array transducer. If available, it's preferable to use a linear transducer that has a smaller, less wide footprint, such as a hockey stick linear transducer. And this is so that you can maximize contact between the probe and the closed upper eyelid. If your ultrasound system has an ocular preset available, you should use that because with the ocular preset, the thermal index and mechanical index are lower, and this results in the eye and its structures being exposed to less energy. If you don't have an ocular preset, you can use either an MSK or small parts preset and then lower the dynamic range and the mechanical index. These are the supplies that you should gather for your exam. So this includes tegaderm as well as packets of sterile surgical gel. I tend to like to use the sterile surgical gel packets instead of the big bottle of ultrasound gel, just because of the concern that maybe some of the gel is going to get into contact with the mucosal surfaces of the eye. So for this exam, have your patient supine on a stretcher. You can also slightly elevate the head of the bed by about 30 degrees if that's more comfortable for your patient. You're going to have the patient close his or her eyes, and then you're going to apply a thick layer of sterile surgical gel on top of the closed eyelid and eyelashes. Then place your tegaderm on top. Then place another copious amount of sterile surgical gel on top of the tegaderm. Then place the probe over the eye with as little pressure as possible. If you use a large amount of gel, you may not even have to make contact with the tegaderm overlying the closed eyelid. One thing that I recommend that's not shown here in this photo is to stabilize the ultrasound probe with your fourth or fifth fingers either on the nasal bridge or on the forehead, and this will minimize the amount of pressure that you're placing the eye. So you can perform ocular ultrasound in either a transverse plane with the probe marker pointing towards the patient's right, or a sagittal plane with the probe marker pointing towards the patient's head. There's also a way to get a coronal view, though this can be a bit more challenging, and I won't discuss that during this lecture. This is a video clip from a patient with a normal globe. You can see here the globe is filled with anechoic or black vitreous humor. Anteriorly, you can see the patient's cornea. Just deep to that, you can see the patient's iris. And just deep to that, you can see the patient's lens. Posteriorly, you have the retina. And then entering the retina, you can see the optic nerve. When performing this ultrasound study, if you're having difficulty finding the ocular nerve, if the patient's old enough to cooperate, have them move their eyes from side to side so that way you can better find the optic nerve. And then once you find the optic nerve, have the patient hold their gaze steady. This can be very helpful when measuring optic nerve sheath diameter. Now, this obviously can be very difficult to do in a younger child who is less able to cooperate. So in these children, one thing that can be useful is having a parent or child life hold a screen directly in the line of their gaze, so either an iPhone or iPad. Additionally, angling the probe slightly medially and caudally may help bring the optic nerve into view. When you're doing this exam, you want to visualize the optic nerve at a point where the margins of the optic nerve sheath are clearest. At this point, freeze your image and measure optic nerve sheath diameter 3 millimeters posterior to the retina. The reason why we measure 3 millimeters posterior to the retina is because cadaveric studies have shown that this is where the optic nerve sheath is most distensible. So you take one set of calipers, you measure 3 millimeters posterior to the retina. That's the A set of calipers that you see here in the image on the right. And then you measure diameter at that 3 millimeter point. And you can see here in this image on the right, this is the B set of calipers. When you measure optic nerve sheath diameter, measure outer wall to outer wall, and pay very close attention to the long axis of the optic nerve because you want to make your measurement perpendicular to this long axis. So when we first started doing ocular ultrasound and measuring optic nerve sheath diameter using point of care ultrasound, I think almost all of us visualize the optic nerve as this hypoechoic structure entering the retina close to a right angle. However, as we're doing these ultrasounds more and more, and as we're doing these ultrasounds more in children, there's been a shift in now our understanding of what is truly the optic nerve on ultrasound and what's shadowing created by either the lamina cribosa or acoustic shadowing. And so we have also seen that in children especially, the optic nerve tends to enter the retina at more of an oblique angle. So right here in this clip, you can see the patient's globe, and you can see the optic nerve entering the retina. The long axis of the optic nerve lies on this axis that's parallel to the white arrow that you can see here in your image. And so when we first started measuring optic nerve sheath diameter on point of care ultrasound, myself included in this, most of us were measuring optic nerve sheath diameter parallel to this double capped orange arrow that you see on your ultrasound image. And so when we do this, this results in an overestimation of optic nerve sheath diameter because we're not measuring diameter truly perpendicular to the long axis of the nerve. And additionally, we're also measuring the shadowing that's created by, again, the lamina cribosa or acoustic shadowing. Dr. Chen does a terrific job of explaining this and expanding on this in his ocular ultrasound lecture in the series, and I encourage all of you to view his lecture for further explanation. Let's look at this clip from a 13-month-old girl, ex-preemie, who had IVH and had a VP shunt, who presented the ED with vomiting and decreased activity for the day. This patient was an infant, so it was hard to get her to cooperate. But you can see here, her optic nerve is entering the retina, and it looks like it's entering the retina at a bit of an oblique angle. When we freeze the image and measure optic nerve sheath diameter 3 millimeters posterior to the retina, we get a diameter of 4.8 millimeters, which is considered elevated in a 13-month-old child. Now, looking at this measurement in retrospect, again, here the nerve isn't entering the retina perpendicularly. The angle is more of an oblique angle, and as a result, this measurement is likely an overestimation. But I think that even with adjusting for the overestimation, optic nerve sheath diameter is elevated for the patient's age. So in children, optic nerve sheath diameter varies based on age. And infants up to 12 months of age, they should have a diameter that's no greater than 4 millimeters. In children from 12 months to 15 years of age, the cutoff is 4.5 millimeters. And above 15 years of age, you use the cutoff of an adult patient, which is 5 millimeters. If elevated ICP has developed over days to week, optic disc elevation can be seen, as you see here in this image. This can take time to develop, though, and may not be seen initially when there is shunt malfunction acutely. So pearls for measuring optic nerve sheath diameter using point-of-care ultrasound. One is to use a probe with a smaller footprint, such as a hockey stick linear array transducer, to maximize the contact between the probe and the upper eyelid. You should use the ocular preset when doing this exam to minimize the amount of energy that the structures of the eye are being exposed to. With younger children, it can be difficult to get them to cooperate with the exam. And so with these kids, get Child Life or the parents to hold a screen such as a phone or tablet directly in the child's line of sight. To minimize pressure on the globe when you're doing this ultrasound exam, you should anchor the probe with your 4th or 5th fingers placed on the nasal bridge or forehead. In most patients, you should try and ultrasound both eyes. And if you have a borderline measurement, measure optic nerve sheath diameter in more than one plane. Let's move on to pitfalls and how to avoid them. Remember that especially in children, the optic nerve usually does not enter the retina at a right angle. So make sure you determine the true long axis of the optic nerve. And when measuring 3 millimeters behind the retina, measure along the true long axis of the nerve, and then measure optic nerve sheath diameter perpendicular to the optic nerve's long axis. Remember again that there is artifact oftentimes on these ultrasound exams around the optic nerve sheath that's created by shadowing from either the lamina cribosa or acoustic shadowing, and this can result in a falsely elevated optic nerve sheath diameter measurement. There is variability in normal optic nerve sheath diameter based on age. Again, 12 months and under, use a cutoff of 4 millimeters. Up to 15 years of age, over 12 months, use a cutoff of 4.5 millimeters, and after 15 years of age and older teens, you can use the cutoff of 5 millimeters that we use in adults. When you're doing these ultrasound exams, try and measure optic nerve sheath diameter in both eyes, and then if there is a borderline measurement, measure in more than one plane. So let's talk about the limitations of this study. Optic nerve sheath diameter measured using point-of-care ultrasound does not replace cross-sectional imaging. This hasn't been studied enough, and for right now, the utility of this exam may be with your first evaluation of these children with VP shunts, presenting with symptoms of shunt failure, and figuring out who needs that expedited workup, stat scanning, and getting neurosurgery on board ASAP, versus who can get their workup urgently instead of emergently. This may change as this is studied more, and as we have more studies what normal reference ranges are based on age, and if these reference ranges are affected by having a VP shunt. Let's review a case that shows how we can integrate point-of-care ultrasound measured optic nerve sheath diameter into the care of our patients presenting to the ED with concerns for VP shunt malfunction. So this ultrasound clip is from an 11-year-old boy who is an X32 weeker, who had IVH and had a VP shunt placed as an infant, who presented to the ED with 2 days of nausea, vomiting, headache, and fatigue. His symptoms started while he was at school. He believes they started shortly after being hit in the occiput by a classmate. They were roughhousing. When he went to school that day, he felt well, and when he returned home, he felt nauseated, fatigued, tired, and had a bit of a headache. Initially, his parents attributed these symptoms to the hit in the head, but then on the day of presentation, he actually vomited, which prompted his parents to bring him to the ED. On exam in the ED, the patient looked relatively well. His vital signs are normal. His neuroexam is non-focal. He's not lethargic. And you can see here on this ocular ultrasound, you can see here is his optic nerve entering the retina posteriorly at a slightly oblique angle. Eyeballing it, it seems a bit wide. So here we're measuring optic nerve sheath diameter 3 millimeters posterior to the retina. Again, we take our first set of calipers, measure 3 millimeters posterior to the retina, and then measure diameter at that 3 millimeter mark. Now here the optic nerve is entering the retina at a slightly oblique angle, and I think that the measurement that you see here on the screen is likely an overestimation, but I don't think it's that far off. This patient's optic nerve sheath diameter, as we measured it, was 4.8 millimeters, and we measured the optic nerve sheath diameter in the other eye as well, and that was also elevated. And in this 11-year-old child, a diameter of 4.8 millimeters is elevated. Again, remember the cutoff is 4.5 millimeters in this age group. And so this was concerning for elevated optic nerve sheath diameter. And so based on this, we expedited the patient's workup, which at our institution included a rapid MRI. He had labs and neurosurgery was consulted. The MRI confirmed elevated ICP, and within a few hours of his ED presentation, he was in the OR with neurosurgery for a ventriculostomy. So I think that this case illustrates the utility of point-of-care ultrasound measured optic nerve sheath diameter in this particular patient population. History of VP shunt with symptoms concerning for shunt failure. And while it definitively doesn't say whether or not the patient has shunt malfunction, we can use it to figure out which of our patients we need to push for an expedited workup. Take-home points from this lecture are that optic nerve sheath diameter measured using point-of-care ultrasound is a quick, non-invasive exam that can be done at the patient's bedside and can be really useful in helping you figure out which of these patients needs an expedited workup. You want to measure optic nerve sheath diameter 3 millimeters posterior to the retina. And remember that especially in children, the optic nerve can enter the retina obliquely, and you want to measure diameter perpendicular to the true long axis of the nerve. Remember that in children, there is variability based on normal optic nerve sheath diameter based on age. In children 12 months and under, you use a cutoff of 4 millimeters. Between 1 and 15 years of age, you use a cutoff of 4.5 millimeters. And in children older than 15 years of age, you use the adult cutoff of 5 millimeters. Sometimes on these ultrasound exams, you can see optic disc elevation. Remember that this can take days to weeks to develop, and optic nerve sheath diameter changes more quickly. Finally, also remember that when you're measuring optic nerve sheath diameter, there can be shadowing around the optic nerve that results from shadowing from the lamina cribosa or acoustic shadowing. This is artifact, and if your measurement includes this artifact, you can get a falsely elevated optic nerve sheath diameter. I thank you all for your time during this lecture. If you have any questions at all, please feel free to reach out to me. My email is listed on this slide. Thank you very much.